Okay, hi everyone, and welcome to the Decolonization, Anti-Racism, Anti-Oppression, otherwise known as DARAO Committee Speaker Series. And this speaker series is entitled Creating Inclusive and Safe Healthcare Spaces with 2S LGBTQIA plus Individuals. Before we get started, I'll turn it over to Salsabila, who will provide our land acknowledgement.
Good afternoon, everyone. My name is Salsabila, and I'm a Master's of Science in Nursing student at Western University. I'd like to begin this speaker series by acknowledging that Western is located on the lands of the Anishinaabe, Haudenosaunee, Lenape-Wak, and Shawanoton nations, on lands part of the London Township Treaty Number 6 and connect through Sombra, Longwood, and McKee treaties and through the Dish with One Spoon Covenant in Wampum. I understand the importance of remembering our connection to the land and our ancestors. In my culture, we place great emphasis on hospitality and respect, which are values I see echoed in Indigenous teachings. Today, I stand with humility and acknowledge the historical and ongoing injustices that the First Nations, Métis, and Inuit people endure in Canada. We should all recognize our collective responsibilities to reconciliation, not only by acknowledging the land, but also actively committing to learning about Indigenous equity. Let us use every opportunity to listen, learn, and contribute to a more just and respectful future. Thanks.
Thanks so much for providing that wonderful land acknowledgement. Is Chazli Musa, who is a full-time faculty member in the School of Communication Sciences and Disorders for 22 years. She's a speech language pathologist and clinical educator with 29 years of clinical experience in the areas of acquired brain injury, fluency disorders, augmentative and alternative communication, and most recently, voice congruence. During her time at Western, she has focused on promoting excellence in clinical education, supporting clinical supervisors, and developing interprofessional education opportunities. She has developed and implemented numerous clinical placements within a social justice framework that included delivering clinical placements in South Africa, Peru, and Northern Ontario Indigenous communities. To offer much needed services to local transgender and gender neutral individuals while embedding student training in principles of diversity and inclusion, she has developed a group-based gender affirming voice and communication training program, currently in the demonstration phase of the project. So thank you so much, Chaz, and we're really looking forward to your presentation.
Hi, everyone, and thanks for inviting me and making me sound so good in that introduction. I hope I can live up to your expectations. I will try to be brief. I have a lot of slides, but this is the situation with speech language pathologists. So I'm going to talk to you about this new program I'm developing and executing, and it's really about the service delivery and the clinical education approach I'm trying to take that we're trying to incorporate here. So right away, to start off with, this is what I'm hoping my conversation will cover. I will probably be off topic, but you can bring me back online in the question period. I wanted to start first of all by saying that I am not part of the 2S LGBTQ plus community, and I'm on a steep learning curve and am quite a burden on my friends and colleagues and other community partners from that community who are right now helping me to inform the work that I'm doing. And so I owe them a debt of gratitude. I'm not a stranger, though, to equity, diversity, inclusion issues, barriers, access, racism. My own personal lived experience of coming, in the early 70s, a long time ago during the Idi Amin crisis in British East Africa. Most of you maybe won't remember that, but South Asians were being massacred and kicked out of the country, which is when, thankfully, Canada gave us a safe place to come. And then I watched for the next decade or two as my parents and their generation struggled with English as subsequent languages, struggled with racism, struggled with barriers to access. And that has really informed both my practice as a speech pathologist over this almost 30 years, and also as a clinical educator lecturer here at Western. And so you see here pictures of various projects I've been part of that already Danielle told you a little bit about the development of these international based placements to make these issues of diversity, inclusion, equity a little bit more salient for the students who I teach, which in general are fairly privileged students of a certain socioeconomic status. So my goal and my personal motivations is to do, social justice through speech pathology and through clinical education specifically. I'm interested in serving marginalized communities, having lived through different things. So some background around gender dysphoria. You must all I'm sure heard that, know and have heard that the incongruence between one's experienced versus assigned gender can really lead to some quality of life and health issues around. We know that the challenges that transgender and gender diverse individuals face are significantly more when it comes to psychosocial, emotional, mental, psychological challenges when compared to cisgendered peers. And so these health challenges are then further exacerbated by the fact that we have very little service available that is safe, sustainable, and friendly for these communities. Very much like we just heard, this is an important part that's missing. And then we also know that voice is a very important part of identity for all of us. That it doesn't matter which community from, your voice is a window to who you are. And so when there is this discongruence, it can have all these adverse effects on quality of life. And so that is partly why I'm interested in creating some programming here where my students can get immersed in this area and get exposure to these concepts and start to build a culturally responsive way of being. Some basics about gender affirming voice and communication training, because language matters and so do terms. And so this is not a voice disorder area in speech pathology. We have a lot of disorder areas, and this is not a disorder area. This is therefore not therapy. We refer to this work more like trans voice work or voice harmonization work, where we move away now from masculinization and feminization of voice, although some people do prefer that. So we are aware of using, understanding how the instrument of voice is made and used in order to help individuals to develop a voice that is safe for them, that provides comfort and pairs with their identity in a safe and sustainable manner, because we have some physical limitations to work with that way. I want to point out that there are cisgendered individuals who seek to modify their speaking voice as well, but that is not the focus of my work at this point. So a couple of years ago, Faculty of Health Science had an internal grant called the Western Learning Lab Grants, and I was lucky enough with my colleagues to get a planning grant that allowed me to run focus groups with end users. And there were three primary groups. There was the group of transgender teens who would use gender forming a voice work as if that was available to them, and also clinical students, because this is where my role is as a clinical educator. So clinical students who had had fieldwork placement experience in this specialized area, and then clinicians, speech pathologists with this expertise knowledge. And I was trying to work on a generative co-design framework, right? So to engage the end users to help inform the development of a model by looking at what each group thinks of as ideals and what they see as barriers, and to inform this development of a service that I wanted to provide here in our on-site community-based speech and language and hearing clinic that we have, the H.A. Leeper Clinic at Alberta College, where I do a lot of my supervision and teaching. So that is what we were trying to do in that first planning grant. We ran the focus groups and we did a thematic analysis where we learned a lot, and I can go into more details if you're interested. But some things we could expect, like there aren't a lot of services out there and there's barriers around how to access them. It costs money. They're not always in a model that's friendly. And there were some findings that really moved me. Like they said things to us that, as nice as our frontline staff are in our clinic, and they could tell we were good people, that we really did not have the knowledge and the understanding of the lived experience. And so that translated into awkwardness, and that created unsafe spaces for them. So the opposite of what we had hoped to be doing. So that was very informative, that we weren't going about this the right way. They also told us things around safety that you could expect around being at Western and the perception of Western not being particularly safe for gender diverse individuals. We learned a lot about family dynamics because in our focus group it was heavy on the teens, and they talked about, divorced parents where the individual is out to the mom but not out to the dad, and then how does the clinic communicate when it's dad's week to pick up the kid, and all the things around the age for making medical decisions and how that prevents them from accessing gender affirming work in general, but voice training specifically. It was really an important lesson for us to learn about the family dynamics, and it is changing how we're approaching things here. So I think that we took away from it many issues. One of the things that struck me the most was that when they were finally able to find a speech pathologist who was doing this work, they felt that the speech pathologist either lacked interest or competency, which made them awkward and again created an environment that felt like they were disengaged. So that it took such a long journey to get to speech pathology, and then the therapist they got didn't have the knowledge or the ability to do this work. So I'm very pleased that my students are now getting some training and in a more holistic way, and hoping to change that picture. So those are some of the lessons. There were many more. I won't go into all of them. So that led to a second planning grant, which allowed me to develop some educational tools for my speech pathology students, some more culturally responsive materials for the clinical service delivery itself, and also an 8-week group-based program to deliver this gender affirming voice harmonization care that we were aiming to serve the marginalized community that we have in London, who are telling us they need this. And I was able to run a pilot group of, as it turned out, adults. No teens signed up for my first group in the spring, an 8-week term. And of course, then we looked at both the pedagogy of the clinical students that were placed with me in that delivery, and then the members who were part of that group got more feedback, more shaping. And I'm happy to say that we were successful in getting a demonstration phase grant, which I'm currently in now. This grant has allowed me to provide some training that is done by experienced facilitators, not just me trying to patch things together, and for our frontline staff, which has been amazing. And then the development, not the development, but the execution of the 10-week group-based gender affirming voice and communication training program, which we're finishing up. Our 10th session is tonight. So that's now the next phases of the demonstration grant, is to now study and research and look at what the group is telling us about how successful we were, what are the shortcomings, and then also looking at the 2 different pedagogies we're using for clinical education of our students, given the times that we're in and what the students are available for. We've got 2 approaches to their learning, to immerse, trying to address some of those barriers from our focus groups is the goal. So highlights of lessons so far is the real importance of the trained facilitators doing the culturally responsive training. So Work Q Shop, which I have a little slide about later, are who we were able to hire to do this training, and they were fantastic. They're a charity-based organization with people with lived experience who are trained facilitators, and they came in and they trained our frontline staff, our clinic staff, the front of the building staff, because of course we live at Elborn College in a building that also needs some work. So that has been really positive. We're looking at the responses to the surveys after the training, and clients are telling us what that they notice that our staff are aware of certain things that they didn't anticipate. So we're trying to turn down some of those barriers. We were so proud of our gender diverse bathroom in the clinic, and that is just really not enough. It's a great bonus and people notice it, but actually there's many small signs of allyship that we should be doing. And so now we have peppered through our clinic and our clinic rooms and our waiting areas many other rainbows and the gender unicorn and some educational material, and it's through the clinic, and that people are responding to, our clientele are responding to much more openly, including other clients we see in the clinic, which has been amazing to see that once you start opening these doors, what can happen. That we do need to remember that this is still a diverse group. We're treating this as another group that we're working with, but there's a lot of diversity preferences. For example, in the spring, those clients being a bit younger did not like that we're working on feminization of voice, that kind of terminology, and their collaborative goal setting was very different than my current group, which is a little bit older, and they're like, please say we're feminizing, because we've worked hard to transition to being feminized and we want to use that terminology. So there's all of that kind of diversity that we're trying to respond to. That just holding a therapy group or a program here has allowed us to start having a role in building in a support into into Elborn College, and that we actually, as healthcare providers, do have a role. And my students are coming and saying things to me like, can't we just give them the space after the program on a Tuesday evening that they could sit here and have coffee, just as a way to build community? Um, and that also we get a little focused because we're a little driven. So that gender identity is important, but it's not the only thing in the picture for the people who are coming for our service. And we remember the whole person. These are just some of the lessons. We have lots more to learn. There's all these questions that are still on my mind after all the learning we're doing, and things that we still have to pay attention to. And there will be more. We're just at the beginning of this journey. I wanted, Work Shop allowed me permission to share some of their slides. And what we're doing in the clinic and in our education model is asking ourselves these questions. We're using this as a practical guide to practical allyship. And then we have input from our end users as well, helping us as we develop the program. Here are a couple of examples of things that we've got around the clinic as, to recognize relevant public events. These are all posted around so different clients, anyone who visits our clinic can see. We try to do some knowledge building around human rights in Canada. A lot of these are shared through that Work Shop. And this is them. If anybody's looking for trained facilitators to train in this area, these are, I would really vouch for them. Okay, that's my synopsis.
Awesome.
Stop
Thank you.
sharing.
Great. Thank you so much, Taslim. That was wonderful. So lovely to see all the things that you're doing in your clinical space to incorporate these great ideas. So thank you so much. And our next speaker, Cody. So Cody is a physiotherapist, assistant professor in the School of Physical Therapy at Western University in London, Ontario, as well as an affiliate scientist with Arthritis Research Canada and a research affiliate with the Community-Based Research Centre. So his research focuses on arthritis, chronic pain, and pelvic health, using a blend of qualitative and quantitative methods to improve patient access to care experiences, and outcomes. In most of his work, he partners with patients and communities, particularly with those who have been historically underserved, such as 2S LGBTQIA+ individuals, to co-develop equitable, inclusive, and sustainable care solutions that respond to the needs and priorities of the people that they serve. So thank you so much, Cody. We're looking forward to your presentation.
Thank you so much. Can we see my slides here? We're all okay? We can hear me okay? All right, great. Again, thank you for having me. I'm really excited to be sharing some of the work that we've been doing. I'm going to try and do a little bit of a couple things touching on concepts, touching on some of the research that we've been working on. And then for those who do work in clinical practice, a couple considerations. And I think it builds really nicely off of what Charlie and Taz have already mentioned. So again, my name is Cody. My pronouns are he or him or il for those who are Francophone. And I always like by sharing a little bit of what kind of motivates me in the work that I do. I am a white settler, I'm a cis man, I'm gay and queer, I'm a Francophone, I'm someone with ADHD and chronic lumbopelvic pain. And so each of these experiences, intersect with each other. They all have an influence on how I navigate my day-to-day and with the people around me. And so there's a lot of alignment in the kind of work I do and kind of how that fits into my own identities. Research-wise, mostly in musculoskeletal health and areas of pain. I'll use queer and trans health rather than saying 2S LGBTQI+ every time through the talk, just for brevity purposes. But yeah, essentially looking at specifically within the populations we're talking about here today, chronic health conditions and health outcomes and how we can improve care experiences. And a lot of my work does involve patient and community engagement. And recently I've been focusing in spaces related to implementation science. Clinically, as a physiotherapist, and I'm taking a bit of a break as I'm adjusting to my new academic role, but it's primarily been in a clinic setting, and queer and trans individuals represented approximately 30% of my caseload, just by the networks of people that I worked with and how people would come and seek care specifically from me. I don't want to spend too much time on this slide here as it has been covered already. But essentially, when we talk about trans and gender expansive communities, we're talking about an umbrella term, and as Taz just put it, of varied experiences that individuals have had, and also highlighting that culture-specific identities also exist. So depending on where someone is in the world, there are gender-related experiences tied to, like I said, cultural identities, and it does vary in what those terms mean depending on who you're asking to. Now, when we're talking about trans and gender expansive communities, we're referring to approximately 1% of the population based off of more recent census, and that's actually the first time we reported those data. So a lot of work to do still, even in how people are represented. But this is likely an underrepresentation for a variety of reasons, fear of disclosure, among other things. I also want to highlight a study that came out from Transpulse Canada's data that represents almost 3,000 trans and gender diverse folks, where individuals 45% of the time reported unmet healthcare needs in the last year. So really just highlighting that there's a lot of work that still needs to be done. When we look at health outcomes, we have higher rates of chronic health conditions and poor health outcomes, and things like stigmatization, discrimination, social pressures, exclusion, and trauma are all things that disproportionately impact trans and gender expansive communities. We also see negative experiences in healthcare, including in physiotherapy, which I'll tie a little bit closer to for today's discussion, which include discrimination and denial of care altogether. And this leads many to delay or forego medical care entirely. So really just highlighting here that our behaviors as peers, clinicians, and researchers are going to have a direct impact on safety and health outcomes for individuals. What is getting in the way of this? So tying it to what Charlie was talking about, concepts of social justice, cisnormativity. So it's this assumption that everyone is cisgender around us. So where our identity aligns with the gender roles that are assigned with our sex assigned at birth. And this shows up in all areas of day-to-day. And in clinical practice, this could be with intake forms, our assessment approaches, the language we use. And ultimately, this will feed into our biases, which can have an effect on people's comfort and care. And these are fueled by, this is the coin model, if anyone's seen this before. So this comes from Stephanie Nixon, who'll be the first to tell you that this is an amalgamation of years and years of work that she just helped put together that really highlight these systems of inequity that reinforce experiences of privilege and oppression, depending on what those systems are. So that's all the isms. And in this context, we're talking about cissexism. That's also interacting with concepts of intersectionality, so coined by Kimberly Williams Crenshaw, where when we talk about concepts of gender, it's not something that exists alone. It's the influence of different social locations and experiences that are influencing someone's experience and care. So really, it's our role as providers, researchers to reduce harm by interrupting these systems and assumptions. So when we think about this, we want to be providing what we call affirming care. So where we can celebrate identity while also validating experiences of oppression that people experience. So really meeting the patient where they're at and providing tailored care solutions. Really, this is not specialized care, it's person-centered care, something that, for those of us who work in clinical areas and education, we talk about this all the time, right? So it's not asking for something that doesn't already exist. If we really think about it, a number of people experience gender-affirming care, but it's not always labeled that way. So cosmetic surgery, for example, is a form of affirming care to one's gender, but it's something that's glorified in some areas, whereas if we're talking about someone's bottom surgery, not always seen in the same kind of way. So when we think about overall approaches to care for trans and gender expansive communities, we always get this question, like, well, what's different? Why should I treat people differently, right? The approach to care is largely the same. At the end of the day, anyone can seek physiotherapy care or any other kind of clinical care. But there are some specific considerations that we can take into account related to gender affirming practices. And these will be related to where someone is at in terms of their transitioning phases, which can include either social, legal, and or medical transition. But what I do want to highlight is that not all trans people will undergo legal or medical transition. This is just kind of a high level overview. I could spend a whole session course just talking about these specific interventions, but they can more broadly be categorized into hormone therapy, gender affirming surgeries, and more non-surgical options. And really, the aim here is to get the benefits of decreasing gender-based discomfort with one's body, as well as increasing confidence, euphoria, and senses of safety for people, which ultimately can boost participation in life and in overall care. Considerations, adverse symptoms are possible, and it's our role as providers to help mitigate these. But for us to say, to stop affirming practices, that's really inappropriate advice. So it's always finding a balance. And for that, we like to use what we call a harm reduction approach. And so here, we're really trusting the patient to balance the affirming practice with the impact it can have. So let's say someone has had top surgery for aesthetic reasons, they want to maintain minimal impact on scarring, but also that may mean they want to move less. So that can have an influence on them getting their full range of motion if they're not moving enough. So we have to balance the sense of euphoria of the aesthetic of the scarring with the movement that's needed to rehab. Really, we want to focus on symptom self-management rather than actual behavior change. So overall patient education on medically concerning symptoms, for example. And sometimes we won't know, right? So educating ourselves before the next appointment. So thinking about doing our own research and seeking sources that are out there. When we think about some of the studies that have been done, overall, this is kind of a seminal study that was done in Australia, where they found that queer, trans, and two-spirit folks identified incorrect assumptions based on their sexuality and gender identity from their therapist. Overall discomfort surrounding the exposure or physical proximity of bodies, actual fears of discrimination and experiences with discrimination, and overall lack of knowledge from their therapists about their specific health needs. And so what we did, this is part of my PhD work, well, in parallel to my PhD work, where we did a survey with PT students in practice, where individuals reported low confidence and overall non-inclusive behaviors for working with queer and trans and two-spirit folks. Overall, they said that education wasn't preparing them for providing affirming care, but they had a strong willingness to learn and felt that it was mandatory, or it should be mandatory content in entry-level practice. We also looked at the experiences of practicing clinicians who identified gaps in knowledge, in overall inclusive behaviors and clinical preparedness. And there was also a lot of observed discrimination and harassment towards queer and trans folks identified by observation. And again, individuals are willing to learn and have support for that mandatory content, but just wasn't there in their education. We also looked at the experiences of physiotherapy students and clinicians who themselves are queer and or trans. And here, individuals reported negative experiences in educational and clinical settings, experiences with abuse, discrimination, overall repetitive misgendering, among other things, seeing non-inclusive learning environments and clinical practice environments, and limited educational support. And so this really shows that physiotherapy is not yet an affirming space for many community members. And this is really affecting who enters and stays in the profession. So I'll also highlight that in these two studies, we had a handful of non-binary individuals and no trans-identifying individuals, which really is telling to how little we actually are supporting, trans folks in our profession. I also want to highlight that there is more work to come where, for example, we're working on an international collaboration with Australia and the US that focuses on identifying fundamental knowledge necessary for entry-level practice for working with trans and gender expansive communities. So I realize I'm a little bit short on time. So people can go back and rewatch the video. But really, just highlighting the idea of safety math, where individuals, anytime they're going to seek care, have to go through this process of risk assessment on whether they want to be coming into that space. And it can be, emotionally laborsome and really exhausting for people. So what can we do to minimize that experience for people, and create a more positive and affirming environment? And Taz talked about some of these. We want to think about impact versus intention. So I use this example: someone's driving and they drive over someone's foot. And they say, I really didn't mean to run over your foot. I swear I'm a good driver. It really doesn't matter how good of a driver you are, you still cause harm to that individual. So it's better to surround the thought process around the impact that it had on the person rather than the intention, where it centers around our own feelings. Again, I'll leave this. People can go watch it after the fact, but some strategies and tips with some examples of considerations for building affirming clinical environments. And really, at the end of the day, the important thing is being open to learning and educating self. We don't need to be experts in this. It's an ongoing learning process. It's important to hold ourselves accountable. And really, when we're thinking about affirming and inclusive behaviors, it can be the norm. It's just us that's getting in the way of that. So call to action really is for us to be able to normalize bodies with individual specific needs in education and practice, recognizing health disparities, but also minimizing further stigmatization. So just thinking of individual needs and really practicing affirming care. So inclusive language and behaviors, harm reduction, interrupting discrimination when we do observe it, and then just advocating for more affirming spaces. And thinking about how that fits into research as well. So here's an example of a study that we're doing right now, that we're working collaboratively with queer and trans communities to identify research questions about chronic pain that are most important to community. So it's a very engaging collaborative process. So with that, I'm going to thank everyone who's been involved in this work, either research-wise, presentation-wise, and highlighting the Queer Physiotherapy Collective. Thank you. And happy to take any questions.
Great. Thank you so much, Cody. That was wonderful. So helpful and so much great information to share with us all. So at this point, I will open up the chat for any questions anyone may have. If you feel comfortable, you're welcome to raise your hand and you can ask verbally. Otherwise, feel free to ask your questions in the chat. Okay, so in the meantime, while we wait for possible questions, so one of the things that you just mentioned, Cody, that statistic about 45% of trans individuals reporting unmet care needs. So I think each of you mentioned some great key concepts to consider that affect care or clinical settings, but what can we really do at an individual level to start increasing our awareness or knowledge and just reduce unintentional stigmatization? And that's open to all speakers.
Yeah, I didn't. I was
Yeah,
just
all
waiting.
good.
But there are a number of things, and sorry, I ran a bit short in time because I was going to go through a bit of those in greater depth. But just thinking of again, some of the things that the way that we communicate with people and some of our actions in the way that we deliver care have a huge influence on that, and in research and in our everyday interactions. So thinking about, there's the obvious thing that we talk about often is use of pronouns and asking people for pronouns, normalizing that practice, because when we normalize it, it makes it easier for individuals whose pronouns are not aligned with, what society would view as, the norm, quote unquote. It makes it a lot easier for individuals to share that. That's one example. You also want to think about the care, not just that we're providing or the recommendations that we make to people. We have to think about referral safety, right? So if we're sending someone to another space that could be putting them in a potential space of harm, that's not a great situation. We want to avoid things like that. So really thinking about, not just the immediate, but potential future for that individual. Those are just a couple examples. I mean, I could talk about a whole bunch of things, but I'll pass it on and see what else the other two would like to add.
Great.
Yes. Can I add something? I've been talking to my students who have been participating in this 10-week program, and one of the things that they have reported back to be productive is this idea about educating yourself and reducing your own biases, like that knowledge from our focus groups the that as nice as people as we are not creating a safe space because of our own discomfort, because of not knowing how to speak about these issues, not being able to take ownership of a mistake and moving on without making it a big production. These are things that are not building the safety that we think it is, and so that was really good to hear from the students, that the provoking of the self journey that I'm trying to do with them as I meet them has been a productive thing. And I'm not sure I've got all the tools to make that happen. But again, that Word Queue shop really did help frame some of that for us. So I think that self-discovery, looking at your own biases, but in a very practical, how is this showing up in the clinic room, despite, as you said, Cody, good intentions, right? So reflective practice, I guess, is another way to say that.
I can add something in here as well, and I think that that might start to address a question that came up in chat as we were talking. When it comes to the role of educational spaces and like not so much clinical practice, like for what I do in anatomy, that we get a wide range of students who may or may not proceed to be clinicians or are already on the path of becoming clinicians. So when it comes to education more broadly, I think the approach that I take with students and addressing this statistic that we saw, where people really tend to avoid care for fear of discrimination, I really promote a culture of curiosity. So in learning, I always ask students to consider what they aren't seeing. So I'm showing you one thing, but what is under the tip of the iceberg that you're not looking at? So this is one example of, for example, the human body and what you're seeing. But what is everything else that you might be missing? And where do you go to find that information? So there's, like Taz just mentioned, like a critical thinking piece and a self-reflection piece that students learn through us modeling curiosity and a willingness to learn, that I think down the line, as we apply these practices with our cohorts of students that come through clinical and non-clinical education within health sciences, we will start to see some positive impacts on care for this population.
That's great. Thanks so much, Charlie. And I think you started answering the question in the chat, which is great. So I'll open that one up also to the other speakers. So in the chat, there was the comment, I'd love to hear about each presenter's top strategies they share with students that will be useful in their future practice. So any other advice to students there as well?
Yeah, I mean, I would just echo what Charlie said. For me, it's encouraging students to be critically self-reflective in every little thing, every little interaction, and often trying to tie it to things that people don't necessarily always think about. I use there's a video that I use, the monkey illusion. I don't know if people have seen that video before, so I can put a link to it in the chat afterwards. But just to highlight that, there are things that we don't, if it's not front of mind and it's not something that we've personally experienced, it's not something that we're thinking about. And so it's easy to miss those things. And so trying to draw our attention to all the little pieces that, we aren't always thinking about. And I'll use an example in physiotherapy practice. We often use mirrors in teaching people exercises. And then I ask students, like, do we see any potential issues with this? And then when we actually get people to think about it, and students often pick it up on their own, considerations for, and this isn't unique to trans and gender expansive communities, but any kind of sense of discomfort with one's own body, and forcing people to have to look at themselves in the mirror while potentially being in an open room around other people can bring on a lot of discomfort for people. And so just prompting with reflective questioning, I find is really helpful, and encouraging students to do the same with each other, just to try and, challenge our brains into thinking outside of the norm of what we see in our day to day.
I think they've said it all, but I'm going to add something about what I'm seeing in speech pathology is around the collaborative goal setting. So it's much more specific, using these principles that we come at it with thinking a person has come in for voice adjustment and what that must be, assuming when the teams were able to say to me, you know, let me bring in the popular culture person's voice that I want to be like, instead of this idea of feminizing and masculinizing. So the words we use, and we're entrenched in some of this in this area, area of practice, we're quite entrenched in feminizing, masculinizing. And so where is the diversity or the nonconformity happening? So that has been a really good way for students to start seeing how they word things and how that leads people down a certain way. And not everyone is comfortable saying, like the teens in the focus group were very, very comfortable in saying, but many of our clients are not able to say, that's really not the way I want to see this. This is what I want my voice to sound like. And I'm not going for more feminine or more masculine. This is what I feel is closest to my identity. So it's that curiosity, and then educating yourself a bit and recognizing collaborative goal setting looks different sometimes than what you're taught.
That's great. Thank you so much, each of you, for your reflections as well. Oh, I think we have one other question that just popped up. So do you have any concerns, cautions, or advice about posting of signage that gives the impression of being a safe space if not all in that space are truly committed to that safety? So example, in a big practice or organization.
I have to say that I ask that question a lot because I can't control, and we have a flow, right? Students are coming every term. We have another 30 coming into the clinic, or another 60. But really, at least from the small samples I've collected so far, people recognize the sticker at the reception desk that shows the gender unicorn, why are pronouns important? They do recognize, and that front desk I'm certain about because they stay stable. In my clinic room, I'm certain about. I think if I worked somewhere bigger, and I right now in a position that lots of people have expressed that they want to create our HA Libra clinic to be as safe as possible, safer instead of the safest, because we recognize we have failings. I think that those small things do actually matter, but maybe in a big organization, you should put them in where you're more certain. That would be my only caution, because I can see the problem and have seen the problem where we say we're a safe space, but then we have one or two people who don't have the awareness or aren't on the same page as us, and that looks like we are being dishonest. So I appreciate the nuanced question, but I have heard from our client group that even a couple of those stickers, magnets, things that we have around in the right spaces with the people who can stand behind them has meant the world to them. Much more, as I said, than the gender neutral bathroom, which did surprise me. So there was my own bias there.
Can I add just quickly to that too? Yeah, so the one thing I will say is absolutely having that as a signal to people of what kind of space it can be, the behaviors do have to match that though, right? So if someone's entering a space where it's saying that it is inclusive, but they enter it and they're not receiving that type of care or experience, that's actually even more harmful. So a colleague of mine is actually developing in physiotherapy contexts. It's actually a scoring system where you can look at a number of different items and considerations that are more, foundational concepts, and then kind of the add-ons that are that it's nice to haves. So if there's misalignment in, we have all of these things that are nice to haves that show it's an inclusive space, but the behaviors don't match it, then there's like a reevaluation process. So that's to come. It's not out yet. But yeah, you definitely want to have the behaviors that match it to signal that for people.
That makes sense for sure. So we're just running out of time. So I'm so sorry. I apologize for not getting to the last question there, but please leave your emails as well in the chat so others can connect with you if they have any other questions. So thank you again so much to all of our wonderful speakers. It was just wonderful learning more about your research areas and some of the things that you do to create safe spaces. So thank you again, and take care, everyone.